We talk a lot about norepinephrine and epinephrine and phenylephrine when we talk about vasoactive substances, but not as much about vasopressin. The typical place we reach for vasopressin is when we have started our norepinephrine, we reach some magic threshold, we want to add a second agent, so we throw some vasopressin on in the background at that 0.03 or 0.04 units per minute dosing. There are some places though where I consider reaching for vasopressin earlier or even as my first agent. The two places that really come to mind are one, in patients with liver failure. These patients live with a vasopressin deficiency, and so what we're trying to do is just give them back their endogenous vasopressin. So whether it be sepsis, hepatorenal syndrome, or even in GI bleed, I'm reaching for vasopressin early. In those GI bleed patients, obviously I'm going to be giving them all of the blood products, but I'm also going to be throwing vasopressin on in the background, again at that dose of 0.03 units per minute. The second place to consider reaching for vasopressin early is in patients who are taking ACE inhibitors or ARBs who come in with shock. Those drugs in theory suppress endogenous vasopressin production. So we are just giving them back their physiologic vasopressin that they are lacking. So there are two places to consider early vasopressin use. Number one, in patients with liver failure because they are endogenously depleted, and number two, in patients on ACE inhibitors and ARBs because those drugs can inhibit production.